Yeah, great to see so many of you here. And welcome to this therapeutic, I hope it will be therapeutic, therapeutic after work hour, where we will get the chance to talk with Professor Åsa Nilsonne, Professor Leslie Greenberg about psychotherapy, and I hope even to get them a little bit better. And please, if you have questions, we will save some time for some few short questions in the end. So please feel free and join in towards the end. My name is Vegard Hanken, and I'm very excited to have two such experienced psychotherapists here with us, who both have been an important inspiration for me and for many others of you. I guess you know who they are since you are here, but let me give them an introduction anyhow. Åsa.
That's me.
Yeah. Good, thanks. Now that's clarified. And you were born on a winter day in 1949 in Stockholm. You grew up in Sweden, but even in Oslo, Lebanon, and for some years in Ethiopia as well. You studied to be a medical doctor, who became a psychiatrist, who took the road of psychotherapy. You were one of the main figures who took DBT to Scandinavia, and your book in DBT was translated in all languages in Scandinavia, and also mindfulness was you were one of those who took that into both mainstream literature and even for psychotherapists in Scandinavia. You have published many books, both in psychology and fiction, so both very scientific and even very creative, so it's like you are both much of an artist and a scientist at the same time.
That's a psychotherapist.
Yeah. Leslie, you were born 4 years earlier, in 1948.
That makes me senior, right? And I believe in celebrating age rather than regretting it.
Sounds good. It was you know this, but it was in Johannesburg you grew up. You studied engineering, and you worked as an engineer before you did a new turn into psychology and became a psychologist when you moved to Toronto in Canada. And there you went into clinical psychology and therapy research, and over the years you developed a method today known as emotion-focused therapy. You have published numerous articles and books, both on individual and couples therapy. You even received many awards for your research. And this week you are in Stockholm to give the first EFT training here in Sweden. That's why you're here. And so, welcome, both of you.
Thank you.
Yeah, one thing you have in common is that you are psychotherapists. And so I thought about starting off there. I guess no one is born to be a therapist, so I wonder what influenced you, or what sculptured you to become a psychotherapist?
Who first?
Age before beauty.
Age and beauty. Whoops. Well, you know, the way I answer this question, it's not totally true, but it was trying to understand my girlfriends. I have two friends who both became medical doctors. I became an engineer because I didn't like biology and body cutting up and so on. And we used to sit around and talk about how to handle our girlfriends when we were 17. And they dropped out and became they became doctors, they dropped out, they became jazz musicians. I became an engineer, and we all ended up as psychotherapists. They're both analysts, but they are Winnicottian analysts, and I'm an experiential therapist. And that the seeds were all there. We were sitting around talking about how to figure out our girlfriends, which was really talking about ourselves and how we felt and how to manage them. And that, I think, was the fact that all three of us became psychotherapists indicates there was something going on there. But I think I was an engineer. I was also a student leader. So I was interested in working with people. And as an engineer, I was hyper-rational, and all the men around me were rational, but I was going on in technicolor inside, but had no way of speaking about it. And I think that sort of was a part of why I changed, because I felt this. I had some issues in my family, but not devastating ones. But I experienced the world in a very feeling way, and I think that helped me to become a therapist, or led me.
Åsa, did you go in a different route?
Yes, very. I think my main inspiration from the very beginning was a chicken.
A chicken?
A chicken, yes. When we were living in Ethiopia, we had the advantage, I don't know if you had the same experience, but we could live surrounded by animals. Did you have animals?
Not really. There were not lions walking down the street
No,
of
not lions,
Johannesburg.
but things
No,
like
I'm
chickens
kidding,
and dogs
right.
and cats and goats and this sort of thing.
No. It was more urban where I...
All right, anyhow, we had these little chickens, beautiful little Ethiopian chickens that would sort of wander around in the garden, and we also had a large dog. And the large dog was not allowed to chase the chickens, but he did anyway, sometimes. So the chickens were, just a bit careful when the dog was around. And then, to my delight, one of the chicken lays a bunch of eggs, and she sits on them for a number of days, like 3 weeks, and out come these tiny little chickens. And what happened then was that this hen, the mother, had a complete change of character. So as soon as the little chickens were hatched, as soon as she saw the dog, she would sort of go like this and make herself very big, and then she would stick her wings out and ruffle up her feathers so she looked 3 times her normal size. Then she would open her beak so she looked like a Chinese dragon, and then she would attack the dog.
Wow.
And I was amazed. I was thinking, how is it possible that there are 2 completely different programs, behavioral programs, in this little beautiful hen, who was my favorite hen. Her name was Henrietta, not very original. And that actually started me on my interest in behavior. And after a while, I realized that you could study medicine and behavior, because Konrad Lorenz won the Nobel Prize for Medicine, and he was a doctor. And I was told by everybody that becoming a biologist or a psychologist was not a good career choice. Becoming a doctor was a good career choice. So I became a doctor. And realized when I did my psychiatry, we had to do 8 weeks of psychiatry in medical school. And then I realized I would not be working with behavior, because all the psychiatrists seemed to me to be crazier than the patients. But fortunately, we had another go. We have you have to do 6 months after your sort of basic training, and then I had a very, very good supervisor, teacher. So I went into psychiatry and completely lost faith, if you like. Rather, I became terrified of the psychopharmacological treatments we were giving, because I was sort of seeing the effects. And I realized that I wanted to be a psychiatrist. I did not want to use psychopharmacological treatments. And so then there's basically just one other way to go, and that is to learn psychotherapy. So thank you, Henrietta.
I wonder what is my chicken. We all have our chickens too.
Yeah.
But and then you worked for many years as a psychotherapist, and if you look back, is there a big difference between you as a young psychotherapist in the beginning of a career and now a senior therapist?
It would be terrible to answer no to that question.
Yeah.
I mean, some people say when they're angry with somebody, they say, that guy doesn't have 20 years experience, he has 1 year experience 20 times over. I mean, obviously, if you think about what you're doing, you have to develop the way of practicing and the way of understanding what's happening between you and people that you're trying to work with. And also, psychotherapy evolves. So there are new psychotherapies to be informed by. So I think there's a big difference.
You know, I'm aware that at mid-career I started feeling I was a worse therapist than I was at the beginning. Because my head,
a worse therapist.
A worse therapist. Because my head was cluttered and I was developing models and I lost my ability to be really empathically attuned and present. Then I regained it, I think. And I think I started off as a very non-directive, empathic therapist, and now I've changed because I combine following with guiding. But to move to be a more directive or leading has been a big change. And I didn't start off with emotion as central. I was young, existential, reading all the existentialists, and I thought meaning was central. And now I think emotion is central. And I think it's deeper than meaning. So, I mean, I've changed. Am I a better therapist now? You know, one of the most humiliating experiences was in one of my research studies with young students. We were all therapists, and I thought I did this really good job in this. They were short-term research-based therapies, and I really did do a good job. And this other student, I thought, didn't do a very good job. The client of the student reported a much better outcome than my client, right? Who knows what's better and what's really worse? It's not so easy to figure it all out, you know.
But if you could look back really and picture yourself as a young therapist, the one you were for in the beginning of your career, everything to learn, if you should say something very short or an advice to yourself, what would that be possible to give an advice to your earlier?
The first thing that comes to me spontaneously is have fun. Enjoy yourself.
Okay.
Follow your excitement and your curiosity.
I can only agree. And I think at the same time, it's not possible to skip stages of development. I think in the beginning, you have to be sort of focused on the interventions and what you're doing because you don't know them well enough. I mean, somebody gave the example of a pianist who's learning a new piece, who in the beginning has to just think about pressing the right, what do they call it on the piano?
Keys.
Keys, the right keys.
Yes.
And only after you've actually mastered the sort of placement of your fingers on the keys, then you can begin to put your emotion into it. So I think the first patients, at least that I had while I was learning psychotherapy, probably profited from the fact that I was so happy to be doing that, and I was so happy to see them. But I was really trying to go by the book, thinking, oh goodness, he said this, what am I supposed to do now? Instead of just going with it. But I think I couldn't have skipped that. I mean, if somebody had told me, don't worry too much about the interventions, I would probably have become dangerous.
Yeah. So to get in some basic and still develop and be...
Yes, because after a while you know what you have to do, and then you can listen without having to think about what am I going to do next.
Do you know what it evokes for me? What I was an engineer, and then I came into therapy, and then I was a South African in Canada. And I became like a cultural anthropologist as a therapist, because I didn't know what these Canadians were like. If they said white, did it mean the same as me? If they said afraid, did it mean... So I was very culturally sort of fragile, and that made me just listen for 3 to 5 years to who are these beings. And that made me extremely attuned and non-judgmental. And I think being non-judgmental was very important and fundamental. So I was sort of more focused on the relationship. And being this cultural anthropologist helped. I didn't have judgments. I didn't know what it meant that you wore pearls or that you wore boots. Whereas in South Africa, I probably would have had a judgment. Oh, that means you're this kind of person. And, you know, so that non-judgmental attitude of acceptance was very important in the beginning.
Yeah, an attitude that I guess you share. Also, I find it a lot in DBT and non-judgmental acceptance.
Because in DBT that is a strategy, but I think I had sort of the same experience having grown up in different countries, that you realize that it's, to begin with, that there's a vast range of human experience that perhaps people who've just sort of stayed in one place don't appreciate as much. And I think it made it easy for me to sort of not worry too much when people were psychotic or doing sort of things that everybody thought was strange, because somehow I was thinking, well, somewhere this is probably completely normal.
Right.
We need to go a little bit into these methods, and Les, you can you tell us why emotions are so important for you, and what? Tell us a little bit what EFT really is. And
I have to do this in a very quick period.
Yeah, right.
I think emotions are the fundamental data of human experience. So whereas Descartes said, I think, therefore I am, I think it's really, I feel, therefore I am. Right? And emotions are our primary meaning system. They're our basic way of processing. They're our primary action tendency system. They orient us to the world instantly and immediately, and they're our primary signaling system. We communicate. If I don't read that my wife's left eyebrow is raised or her voice is one octave higher, I'm in danger, right? So there's communication going on. So emotion is meaning, behavior, and communication. It's our most complex processing system. So that's... The thing is, when I came from engineering, I had this feeling that I knew more than I could say. Now, Polanyi was a philosopher who'd written about this phenomena, that basic scientists have this, you know, what we can simply call a gut feeling. And I was very interested in math and physics and solved a math problem that nobody else in my class solved in a final exam. But I didn't know how I knew how to solve it. I just did it. And that fascinated me. And so I started trying to understand tacit knowledge, knowing more than I could say. And then it came eventually to seeing that emotion was giving me this orientation system, and that it was fundamentally a healthy adaptive system. So I've actually forgotten the question you asked me, but that's...
But you are answering it,
right,
actually,
right.
yeah. But while you are into the emotions, there is this slogan that you often, I hear you say in your books, is that we can change emotions with emotions. And could you try to say something about that shortly? What does that mean?
Yeah, and I have two other little sayings, which you have to arrive at a place before you can leave it, and you have to feel it to heal it, right? So my idea is that you have to first arrive at the very painful emotion, which are usually shame, a feeling worthless, insecure attachment, anxiety, fear of danger. There's some very core painful emotion. You have to arrive at it before you can leave it, right? You have to feel it in order to heal it. But then I believe a lot of therapies, starting from Freud, try to approach that emotion through insight, through cognitive restructuring. But I believe that these amygdala-based emotions are impenetrable to reason. So how can we help people change? And I believe that the best way to change an emotion is with another emotion. Spinoza, the Dutch philosopher, was the first person to write that the only way you can change an emotion is with an opposing emotion. And I'll just hint at that each emotion has an action tendency. So in anger, you puff up and thrust forward to protect your boundaries. In fear, you're organized to run away. If you're in a fear state and you're organized to run away, you can't puff up and thrust forward in empowered anger or assertive anger and run away at the same time. So the empowered anger is going to change the fear. So one emotion can change another emotion. And I think this is a very important but relatively novel idea. Although behaviorists, Walpe, he was a South African psychiatrist. I never knew anything about psychiatry in South Africa. But they showed that anger changed fear. But they didn't have a theory of emotion, and so they dropped that and they went to relaxation is a reciprocally inhibiting response. So relaxation will change fear. But they actually showed that anger changed fear. And they lost it because they didn't have a way of understanding it. So I think one emotion could change another emotion.
Yeah. A little bit like the chicken, who was first afraid and then puffed up.
It's fascinating, yeah. I mean, there is...
But that was contextual.
Yeah.
And I mean, with the patients, we're trying within the same context to change the emotion, so that's a little bit different, I think.
Absolutely. But also, can you say something about, you chose also psychotherapy and DBT, and could you tell us what you were drawn to by psychotherapy and dialectical behavior therapy in particular?
Well, psychotherapy, just because I wanted to be in psychiatry. Passing through medical school is a bit like speed dating. You sort of go to an orthopedic department and you start thinking, well, this is what I'm going to do for the rest of my life, sort of help people who've broken their bones, etc. And then 3 weeks later, you're looking at little kiddies that have been born prematurely, and then you think, well, maybe this is what I should be doing. But I wanted to work with psychotherapy, with psychiatry, because of all the symptoms that I sort of observed during my training, I thought the ones that the psychiatric patients had problems with were by far the most interesting. You have difficulties in thinking, in feeling, in adapting your behavior to the circumstances. Seem just more interesting than rashes or jaundice or something. And if you're going to work as a psychiatrist or as a doctor, you're expected not only to understand what you're doing, but actually do something about things. And if you can't use drugs, you've got to do something else. So psychotherapy was the only thing that I could, it was the only way that I could go.
Yeah. And what did you find there? Because I believe it was DBT, and what did you find that you found important?
Well, DBT actually came later. It started out with cognitive therapy, and there I found something very different from the psychoanalytically oriented training I'd been given earlier. In the cognitive therapy, I found a therapy that would actually say that the patient is probably able to give a correct description of what they are thinking and feeling, whereas my more Freudian supervisors would say that the patient doesn't know. You know that the patient is angry. The patient thinks she's unhappy. But in fact, because the theory says that she's angry. And I always thought that was a very disrespectful way of interacting with people. And I had a lot of trouble adjusting to what was expected of me as a sort of psychodynamic therapist. And then when cognitive therapy arrived, there was no problem with that, and there was no problem in working collaboratively with the patients, sort of saying, well, I don't know what this is, and you don't know what this is, but let's try to find out together. And also it worked. And then I was recruited to DBT. I was headhunted to a large DBT project. And so that made me really happy, because to begin with, there was a therapy put together by a woman, specifically for women, and it addressed the problems of a group of patients, which were then called borderline patients, that were actually not well taken care of. People didn't believe that they could sort of function in a psychotherapeutic setting. People believed that they were evil almost. They were manipulative, they were disruptive, they were people nobody wanted to take care of, and they were given terrifically bad treatment. So it seemed like a wonderful thing to do, to sort of try to bring DBT to Sweden and see if it would work in Sweden, it was brand new, so nobody even knew. Marshall Linehan, whom we went to train with later on, was this extremely powerful person. You know, some people are like that, they just walk into a room and almost everybody goes like this, automatically. And so people were saying, well, you know, no wonder Marcia's patients get better, they don't dare not get better. But nobody else can do this. And so we were left with the question, those of us who are not like Marcia, could we use this therapy in a way that would actually be helpful? And it turned out that yes, we could.
What are you happy about to get from that when you went back to Scandinavia with that method? And what did you learn from Marshall Linehan that you found it?
Oh, we learned lots of fantastic things. We learned, for instance, that you don't need to... We learned that these women, they were just women, are actually doing the best they can. Even if they're cutting themselves, or even if they're upending the tea wagon and sort of breaking things, at that given moment they are solving the problem to the best of their ability. We learned that this is very often a post-traumatic situation. It's not sort of bad genes, and it's not sort of somebody being infused with the devil, as I've actually heard a colleague say that. Can you imagine? I mean, a psychiatrist says to me, these patients are the incarnation of the devil. That is how he felt about them. And can you imagine what it must be like to come and see a psychiatrist who believes that about you? So it was nice to sort of have a structured framework that showed what most of us that have been sort of enjoyed working with this group of patients always had felt, that these were pretty normal young women. And never mind that they get 23 diagnoses with our current diagnostics system, which is ridiculous. And never mind that they get over-medicated. So it felt very hopeful, and it felt like a sort of gesture of female solidarity, and this nice sort of feeling you get when you're doing work that nobody else wants to do and it's actually working out well. Actually, people thought we were crazy, literally. And fortunately, it all worked out quite well. And I like this thing with opposite emotion, because in DBT we have skills training, and one of the things the patients have to learn by heart like this is opposite emotion. What is the opposite emotion of shame? Well, it's pride. So what can you do if you want to sort of down-regulate shame? Well, you can think of something you're proud of. And if you're feeling too proud, you can think of something that you're ashamed of. So we actually use this very actively all the time.
Yeah. I mean, I'm aware of opposite action. Didn't actually know that it was now using opposite emotion.
It's the start, and that sort of comes out as opposite emotion, action.
Action,
right. Go all the way down the line.
Right, I understand. But what I find fascinating is a real similarity is this view that the client is doing the best they can, and really seeing the positive in people and not being the expert. And I mean, it's the reaction to the psychoanalytic. I mean, for me too, it's like they were the experts and they were pathologizing, whereas I see people as doing the best they can, and this notion of having unconditional confidence in my client, even when it's terrible, it's somehow finding what their resources are, seeing them as having the potential. So it takes me seeing the possibilities in you for the possibilities to be validated and come alive, right? It's not just in you, it's between us. And if I see it in you, it really helps it to come alive, so to speak, But the other thing that's interesting about this is I've just been thinking while I've been listening to you, you started with observation of behavior in Henrietta, was it, right? I started with experience of emotion inside. And I've always thought this of DBT and EFT because there's a kind of potential blending or EFT could be stage 2 of DBT, that DBT focuses on behavior, EFT focuses on internal experience, and not that DBT doesn't also focus on internal experience, but really it starts with behavior, as I see it,
Yes.
whereas I start with experience. And so we're working from the outside in or from the inside out.
And actually, that's something I missed in DBT, the fact that it's quite cerebral. And most of us, when we experience something, we don't experience it here, we experience it here or there. And I always thought that it would be so nice. I actually went to some workshops to learn more about body-oriented therapy, which was very, very useful.
Mm-hmm.
But sort of trying to see that from a biological point of view, biology is not Cartesian, dualistic. You have a sort of unit, which is the individual, and the experience is a part of that. And I missed that in DBT and trying to compensate by bringing in sort of stuff from inside.
So how can we do that? How can we take the body more into that, or the experience more into psychotherapy? How do we do that?
Well, I think by attending to it and by attending to sensory motor processes. So there's all kinds of movement going on, but there's attentional allocation. People, I like to say now with iPhones and everything, I mean it was true before, but the attention is outwards. And then how do you bring the attention back in? And of course meditation is training people in that to some degree. I work differently than with meditation alone, but it's like focusing on your bodily felt experience and also paying attention to bodily movements and so on. I mean, that's one of the important things, training people in more sensitivity to that. But it's all kinds of things. We have a vocal quality scale, so listening to the voice, and what is the voice expressing, looking at the face, what is the face expressing, and so on. So I think those are all important aspects.
Also incorporating, one thing that I learned on one of these workshops, which was so useful, was if you've got a patient who doesn't know where her personal boundaries are, which is quite common, you can, if it's all right to touch the patient, you can stand up and actually approach and I can show you. Would you like?
Do I dare? Yeah.
Yes. So just getting out of your chair helps.
Yeah, I feel different already.
And so you go like this, and you say to the person that this is approximately, the space. This is the space which is yours.
This is between.
Yes, and if somebody wants to come inside that space, you have to give them permission. And now I'm going to try to invade your space. So this is what the patients will do. They won't sort of push you back, and then you can play with that and say, "Goodness, what happened?" And let me show you how I would have done it. Now you try to invade me.
Oh, you're resistant.
I'm not going to be invaded.
Yeah,
but
I can really feel that.
Now you're welcome. So now you try to stop me again. So here I am, I'm going to invade your personal space. Come on, push back.
Yeah.
You're stronger than that. Come on. Something like that.
I'm on it. Yeah, and what I immediately sense that you feel something different when we do that. So the body is coming in, and I was, more of me was activated.
Exactly, and so this was just a short bit, but I've had some patients who sometimes said, "Can we go up and do this thing now?" And then I've known that I've pushed them too far, because then they need to sort of physically feel again that they are in control. And so I think incorporating that sort of work into what you're doing, instead of just sort of sitting as if you were nailed into your chair, and even the distance between the chairs, you could ask people, do you think this is a good distance? Are you comfortable?
Yeah.
Would you like to move your chair? And sometimes they will move their chair further away, and sometimes they will come closer. Who am I to say that this is the perfect distance?
Right.
And that's also bodily.
Yes.
I mean, it's in our skin, it's not in our head.
Yeah, we need to check inwards a little bit to know how to answer that question for the chairs. For
exactly.
example. Someone said, I'm going to this debate tonight. So, so now I'm having thoughts: are we on a debate, or is it possible to get a debate, or is there anything you differ on? Is there anything you can disagree on? Please.
Well, we brought up this issue we were discussing before, on which I thought we might disagree, and that's on, well, not disagree, but have multiple perspectives on the notion of emotion regulation.
Yes.
Emotion regulation has become a new catchphrase. In fact, the American Association of Psychology is trying to set up and asked me to be on a guideline committee for transdiagnostic treatment, which is now no longer for depression, for anxiety, and so on, and on processes, transdiagnostic processes, i.e. they apply across all so-called disorders, right? And they suggest emotion regulation. So I wrote back and I said, I'll be on this on two conditions, because they're very political, these organizations, about trying to show that there's only research that shows that CBT works. But I've just been on a depression guideline committee for 6 years, which finally has said the king has no clothes. And it's come out and it's said there is no evidence that any treatment is any better than any other treatment for the treatment of depression. And that, I think, is the most honest statement that can currently be made about research. But there's a lot of political investment in showing that one acronym named therapy is better than another. But I think because of this, APA is saying, okay, if all treatments are sort of equal or not different, those are two different statements, then let's start looking at these transdiagnostic processes and emotion regulation. So I said, if emotion regulation means down-regulation of emotion, I'm not sitting on this committee. I think we need to think about emotion regulation in a much more diverse way. There's up-regulation and there's down-regulation. And that there's different kinds of regulation, and I distinguish between coping regulation. To give you an example, when I come, I'm a little anxious now as I'm saying this because I'm touching controversial issues, but normally when I come and I give a talk, I don't want to have to use coping regulation, which is, I'm feeling anxious, but now breathe, now look at the people, find a kind face, it'll be all right, I've done this 100 times before. That's coping regulation. It's a skill that helps me cope, but I'd rather get up and just have the right amount of anxiety that'll help facilitate my presentation. So one theory of regulation, I call it two-factor theory. You have emotion and you have to regulate it. I don't buy that as a good way of living. I have a single-factor theory, which is emotion becomes regulated. So how do I help people to become regulated rather than how do I help people to cope by regulating? Now that's important when you're highly dysregulated, to cope, but it's not a good way of living. So I think we need other processes, which are things I'm involved in, but how do we help people to become regulated? So that's my speech on regulation. And then I use the notion of DBT has a lot of skills for coping regulation. But I'm more interested in implicit development of regulation and how to achieve that. So maybe, we did discuss it a little beforehand.
So I think the way one perhaps thinks about this also has to do with the kind of the sort of problems the people one has been working with, have been experiencing. Because I've worked almost exclusively with highly suicidal, self-injuring, borderline people. And then obviously a sort of first priority will be to sort of help them down-regulate distressing emotions to the point where they don't try to cope by committing suicide or by harming themselves. And then the second or third or fourth level, there's a lot of work to be done. Of course, the ideal is, of course, that they should not need to down or upregulate emotions. So that's sort of, but that's the next step. So I don't think these two approaches are actually in contrast to each other or different ways of doing it. But just to me, it's what is step A, what is step B, what is step C.
Yeah, I agree. But I think what's pervading the language of the field now, including psychodynamic people, they say we help people regulate their emotion. So everybody's naming this as a process, and it implicitly means downregulate emotion as a coping skill. And I think that's going to be the real next problem to overcome, because it's becoming the kind of fashion.
Listen, it's very sad, isn't it? Because, I mean, a lot of people who work in psychotherapy do this because they think that psychotherapy is better than pharmacotherapy. And what pharmacotherapy does, of course, is to downregulate emotion. You're anxious and you're given an anxiolytic, you're depressed, you're given an antidepressant. And it would be very sad if psychotherapy were to go the same road.
Yeah.
You're feeling anxious, well, let's use some nice strategies or approaches that we have to make you feel less anxious instead of trying to solve the problem.
Yes, so it becomes the equivalent of psychoactive medication, downregulation. You know, there's this fascinating phenomena. When I was younger, I used to think it's oversimplified to say I don't like the notion of avoidance of emotion. I think people protecting themselves against emotion is a better term. That's the source of dysfunction. I used to think that was too simple because I was into complex meanings. But actually, after all these years, I think that's the problem. That it's the avoidance or protection against emotion that is the fundamental process that causes dysfunction. And it's a fascinating question which I can't answer, which is why universally are people afraid of their emotions, Now, firstly, it's because men dominated, and men are much more afraid of vulnerable emotions than are women. But I use this kind of example. Once my 12-year-old son, he had a high fever, and apparently it's not unusual when you have high fever in children to have delusions. But I came into the room, and he was terrified. He was wide awake, but he was in I've forgotten what it's called. But, you know, he was awake, but in the delusion, right? And I spoke to him, and I said, Ari is his name. Ari, it's all right, I'm here, you're safe. He just said, they're coming at me. The only thing I could do was put my arms around and hold him. I felt his heart rate was beating like it was going to explode. Well, that little 12-year-old is going to say, I never want to feel that again. I'm going to start controlling my emotions. When I was a 16 or 17-year-old, I still have my diary. I was an engineer. I drew a diagram, and I still have it, of a sine curve, which is up and down, with a flat line in the middle. And I wrote there, I'd rather live on this flat line than suffer the ups and downs, the slings and arrows of outrageous fortune, right? And so there was a young man, you start developing this cognitive ability, and you think you can control everything, and you start trying to control yourself, because emotions are passions. We are passive in relation to our emotions. They come unbidden. They're an automatic process, and we don't like not being in charge. So we try to stop them. And this seems to be a universal phenomenon, the fear of emotion. And I think that's the source of a lot of human distress. It's the fear of emotion. And therapists are afraid of emotion. And psychiatrists are doubly afraid of emotion.
We're not going to have it's not going to be easy to find an argument, because I so agree with you.
But what should I do? What should I do then? When I came in here now, and I felt really my heart beating and little panicky going on.
You need some coping
I
regulation.
needed some coping, yeah. But fortunately I've been to DBT training, so I could do some breathing and it helped, yeah.
And
So
does it matter?
I don't know.
I mean, that's one question you could ask yourself.
Does
it matter?
Does which matter? Sorry, I didn't.
You're going to speak to us in English, which is not your sort of mother tongue. A whole room full of people are watching and you get nervous. Does it matter?
Yeah, let's move on.
Seriously, I mean, I think to me acceptance of emotions is a large part. I mean, just accepting that being human or being any kind of mammal, maybe because dogs get terrified and horses get terrified, and it's just part of our life. Experiencing the ups and downs, and some of them are wonderful and some of them are terrible. And both the wonderful ones and the terrible ones come and go, and
To try to generate debate, I don't think accepting emotion is enough. The humanistic therapy started off in the 60s with a basic notion that you need to accept your emotions. But I would say you need DBT skills to cope with this anxiety. Does it matter? Well, it's good to accept it, but also you could go into EFT and change it so that you will get up here, even in English, with lots of people, and you just won't find your body organizing into a more anxious state. And that's transformation. And they're both important, but they're different processes. And we need both of them, right? But the field has gotten sold on shortchanging. It's like, because of economic and political pressures, it's go into hospital, get out of hospital, give people coping skills, and then we've helped them. It's true, but we haven't given them a quality of life that is really needed to live a really satisfying life. So it's sort of settling for too little. I mean, of course it's very complicated, and I'm not saying that's what anything does, but the system forces that on us too. But it is a real economic dilemma.
But I think this is interesting. If you came to me as a patient, I would probably say embrace your humanity. People get nervous. Allocate your attention, I think was the words you used. Focus on what you're supposed to be doing, it will pass. But what would happen if Vegard had come to you with this problem? I mean, how would you find the transformational potential in this difficulty that you had?
Well,
what would you say to him?
I would start saying, so there's this anxiety that comes up, right?
To speak to him, I'm listening.
And, it might be helpful to look at how that you produce that anxiety, or what goes on in your head that produces it. So if you're willing to try something, I wonder if you'd be willing, we're going to set up a dialogue between two parts of yourself. Can you come over here, and in this part, you'll kind of do the things that go on in your head that make you feel anxious. Or maybe even be the people. Imagine you're the people, and they're looking at you. What are they saying, or what do you imagine they're thinking? And then we would help create the anxiety in that chair with the agent of the anxiety being your own internal process. And now we've set up a dialectic between...
So you really mean that I should sit over there and tell me that they are thinking I'm a fool, they think that I sound strange?
Yeah.
Really, yeah.
Yeah. Is that what you do inside? Yeah. So if you would come over here and to do it, right? And then what do you feel when you get there, right? What happens in your body?
Yeah. No, I feel under pressure, and a bit scared and wanting to hide or get through this.
I imagine, and I wonder if we can sort of breathe into that and really accept it, and eventually we might go to, where did this voice develop in your life? Where did it come from? And, you know, who knows what will evolve out of that. I mean, that's how I would begin to approach it. You know? And eventually get to what does this part need from that anxiety-producing voice.
No, I need you to be nice.
No. What do you need from this voice?
Okay, thanks. I see that the time is going quickly, and I know that both of you have also been into couples therapy. You have written many books on that and do workshops on that. And I know that you, together with Anna Kove, wrote this book Tillsammans, and you know, relationships and couples and partners, and it's a hard, what do you say? It's a challenge sometimes. And what do you think is important to make relationships healthy or lasting, or what's that?
Well, that is a really large question, but I think there are several things that can make relationships perhaps a bit less vulnerable. And one of them is genuinely trying to understand and respect and like the other person, to sort of start out with a sort of idea that this person is also doing the best that they can in the relationship, and then to have some what is when you sort of also look at yourself, what do you call self-criticism? Self-criticism.
Self-reflection.
Self-reflection.
Hopefully not criticism.
Or also self-criticism, because
constructive criticism.
yes, because I mean, in many couple situations, you wind up with this: my truth is the truth, and your truth is wrong, and I know what's best, and you don't, etc., etc. But to sort of remember that this is probably not true, and to think that life is short, and you don't have a lot of time to waste being angry or judgmental or unhappy. I don't know.
Interesting. I mean, because I've written many books on couples therapy, I'm translating it into my language, but I can't disagree. But I think,
again,
I think compassion and compromise. When I was 25, I thought compromise was a dirty word. It meant giving up what I really wanted. Compassion and compromise, and you know, this compassionate attitude to really understanding the other and realizing they're doing the best they can. I mean, I use those words. But the best way of helping your partner to be compassionate to you is disclosing your vulnerable emotions. So people are afraid of really showing up. For 30 years I taught couples therapy, but it was very difficult to say to my wife, I feel shame when you said that. Not you make me ashamed, but I feel small and I feel kind of inadequate. It's very hard to do that. But if I can do that, rather than attack. Now this is in therapy. People in life don't do what they do in therapy to change. But in therapy, getting people to disclose their vulnerable feelings to each other is a way of creating a real compassionate response in the other, or can. So I think though compassion, compromise are very important. And really, I believe, along with Buber, that it's the I-thou dialogue between two people, where we really speak, and you use the words, with respect, but we really show up and we do talk about our very primary vulnerable feelings, rather than the blame and the defend that they turn into. So we really show up and we have a real dialogue, and we are compassionate to each other. And somebody had this phrase that I think is very interesting, is relationships get bad all by themselves. That means we have to work at having a good relationship, right? And if I was to give any advice to my children, it's you have to work at your relationship. Don't just expect it to work.
And to work on it, it's important to be respectful and try to understand the other, be self-reflective and compassionate, and have the courage to show some vulnerability or your own emotions to your partner.
And to forgive the other for being different.
And to have fun.
Yes, yes. Yeah, and you did say that too. I think that's an important piece. You've really got to like the other and enjoy the other, and that helps if you really have fun. You know, you are doing things that are enjoyable.
Yeah. I'm glad you said, yeah, we even got in fun there. It sounded so serious with only compassion, self-reflection, and understanding, and fun. So, the hour is getting to an hour, and I wonder if we should open up for some questions out there. And,